This is Module 4, and again, it comes in two parts, and we'll start with Part 1 for Module 4. Module 4 is on Exam 4, and I will be, at the end of Part 2, I'll review for Exam 4. It begins with page 3 in the course pack, and the first part of this is called Normal EKG Response During Graded Exercise Testing, if you go to that first slide. And with some of the abbreviations here, then the graded exercise testing is usually just called GXT, and I'll refer to it as GXT throughout. And that just means that you are not necessarily on a treadmill grade or anything, but it could be on a treadmill or a bike or anything, and you're just adding work to the test, making the test harder throughout. So you have usually stages: stage 1, stage 2, stage 3, and that's referred to as a GXT. We'll be looking at, first of all, normal EKG changes. So these are things that should happen in somebody without any heart disease or any other disease as they are tested on a GXT. And then eventually we'll look at the abnormal response. Under normal EKG changes or responses, we'll look at page 63 in the course pack, which has the outline for this, and then we'll go right through that outline and talk about each one. With each one, there's an example in the course pack that we'll look at to understand what's going on. So with that in mind, then, the first one is the R to R interval. This is on page 64. And the R to R interval is just a representative of a faster heart rate. So if you measure from R wave to R wave at rest, you're going to have a greater distance than you'll have at submax or max exercise. And this just means that the heart rate is going faster, and the interval then is, the R waves are happening faster. So it is normal for the R to R interval to shorten with exercise, just because of a faster rate. That's one of the, some of these first ones are fairly straightforward, and that's a fairly straightforward concept. The next one, number 2, is the P wave. This is on page 65. And first of all, the statement, it is normal for the P wave to become taller with exercise. And that just means that if you're looking at 65, the P wave at rest is its normal height, and then with exercise it becomes a little bit taller compared to rest. And one of these reasons is that there is more filling, more right atrial filling of blood during exercise. If you recall from human physiology, there's more venous return, more blood coming back to the heart, and this is usually due to constriction of the inferior and superior vena cava, and it is the filling of blood is actually kind of a transient hypertrophy in that area. So more blood in there will lead to a taller P wave. The second reason is that if you have beats that are occurring faster, there's not as much time in between the beats for the P wave to completely start at the baseline. The preceding T wave is in position to where the P wave sometimes will come off of that T wave, coming off of that T wave from the beat before it, and this makes it taller because it's just starting at a higher point. So it's normal for the P wave to become taller. Those are the reasons. 65 is the example. The next one is the PR interval, and this is also on page 65. The PR interval is something that should shorten with exercise, and it's normal for it to shorten, and it usually does not shorten right away. It usually takes about a minute, and what's happening with a minute then is that you at first the AV node delay is in place, but then after about a minute of exercise, the sympathetic branch of the autonomic nervous system kind of takes over and makes things happen faster, and so the PR interval then will shorten after about a minute of exercise. You can see on page 65 that there's a short PR interval. The next two I want to take together, and this is 4 and 5 on the outline on page 66 in the course pack. The R wave amplitude and the S wave amplitude and the QRS complex amplitude all go together in this concept. You can describe one or the other or all three they're all the same concept. And we're looking at the amplitude or the height of these waves. And the statement is that it is normal for these amplitudes to increase during submaximal exercise, but then decrease during maximal exercise. The example on page 66 shows max exercise, and if you compare in V1 at rest, the S wave has gotten a lot smaller at max exercise, and then in V2, the R wave and the S wave have both gotten smaller, and the QRS complex is smaller as far as amplitude at max exercise. At submax exercise, they often get a little taller, and this is because these amplitudes are roughly equivalent to the end systolic volume. And during early exercise, there's a greater end systolic volume, and that's making the waves larger because more blood is coming back to the heart. During peak exercise or max exercise in a normal heart, there's a real strong ejection fraction, if you think back to human physiology. And this means that the heart is contracting very strong in a normal heart, and that blood is being sent out to the body, and therefore very little is left in the heart. There's very little end systolic volume. And because of the low end systolic volume, these waves tend to get shorter in amplitude. They get smaller. And so that's the normal response then for them to increase during submax and then decrease during max exercise. When we talk about abnormal EKG during GXT, we'll expand on that topic and talk about a failing heart. But for now, that's the normal response. So that's 4 and 5 together on the outline. The next one, number 6, is on page 67. And this is the J point and ST segment slope. And we've not talked a whole lot so far, just a little bit in the course about the J point. But this is where we start to expand a lot more on the J point, and then continuing through this part of this module, and mainly in this first part of this 4th module. We'll have a lot of discussion on the J point. And then the ST segment slope we'll be talking quite a bit about too. First of all, the statement is that it is normal to have some J point depression with exercise, as long as the ST segment is quickly upsloping and gets back to the baseline in about a box to a box and a half, and that would be 40 to 60 milliseconds. So the J point again is when the S wave is coming back up, it goes from a vertical direction to where it starts to have an inflection point to where it goes more toward, there's a change in the slope. Not horizontal, but goes more toward horizontal or less of a upslope. And so you'll see that change in the inflection point. You can look on page 67 and see the S wave coming up in each case, and then there's an inflection point where there's a change in direction. That's the J point. So the J point can be at the baseline and be normal, but it can also be, as stated here, it can be underneath the baseline a little bit, as long as the ST segment is quickly upsloping and gets back to normal. On page 67, those are normal responses. The J point is a little bit below the baseline, but it comes back up real fast. So that's a normal response. We'll talk later today about a J point that's quite depressed and comes up slowly, and we'll be exploring that later. The next one on page 68 is the T wave amplitude, and it is normal for the T wave amplitude to increase with exercise to become quite tall, and this commonly happens in recovery. The T wave amplitude is related to or correlates with the stroke volume. And so if somebody has a really good stroke volume, the T waves can get taller at peak exercise or even into recovery. And page 68 is an example of this. This is where I was doing a test on somebody that was an athlete, and they had a really high stroke volume toward the end of exercise. They had an ejection fraction of about 95%, and that highly functioning heart, that very well-functioning heart, was contracting so strong that the T waves got really tall. And so it's normal to have that increase in amplitude with a greater stroke volume. And 68 is a good example of that, those tall T waves. The next one on page 69 is what's called the TA wave. And the TA wave is where you have where the atria are repolarizing. And a lot of times you don't see the TA wave. You don't see this process of atrial repolarization. And again, repolarization, as described earlier in the course, is where you have potassium ions going back into cells. And during exercise, you can form what's called a TA wave. The T is meaning repolarization, and the A stands for atrial repolarization. So if you look on page 69 at the top where the arrow is, where the P wave ends, the PR segment does not go flat at that point like it usually does during rest. In fact, at rest it does go fairly flat in that area. But during exercise, there's a TA wave, kind of a downward direction right after the P wave. That's where the arrow is on page 69. And you can also see that on page 69 at the bottom. There's kind of after the P wave, there's a downward direction of the what's called the TA wave. And so this can form during exercise. It's normal for that to form during exercise. So 69 shows you a couple of examples of that, the TA wave forming. But the implications of this are that it pushes the PQRS junction down. In other words, where you start the QRS complex, either with a Q wave or with an R wave, is pushed in a downward direction. And this will have implications later today, not too long from now, when we start to read the ST segment depression, the amount of ST segment depression. In fact, just as a preliminary look at this, if you look at 69, and we'll actually show this same EKG a little bit later in the course, right above the number of the page, there's an arrow showing the TA wave and then the amount shaded in of ST segment depression. And we haven't studied that yet, but in this case it should be read as about 2 millimeters. You can see the shaded part, 2 millimeters. And if we didn't know about the TA wave and we went from the isoelectric line, this might be a good time to even stop or pause this and look at this carefully. If we went from the isoelectric line, it would be actually read as 4 millimeters. But the correct way to do it is from the bottom of the TA wave. So we will get back to that concept a little bit later, a few minutes from now. But that's, again, it's normal for that to form during exercise, the TA wave. The next one is the U wave. And we have not said a whole lot in this course so far about U waves. We will as the course goes on, because we have there are a few concepts that we'll be addressing regarding U waves. But I did mention it early in the course. And a U wave is a wave that occurs right after the T wave and before the next P wave. And it's usually kind of a broad, flat wave compared to the T wave. And in fact, if you look at page 70 where the arrow is, you have your T wave. And then before your next P wave, there's a little bump in there. It's not real pronounced, but usually U waves are pretty small and often tough to see, but you can see like a little bump in there, and that's the U wave. And we'll be talking later about the U wave regarding abnormalities on the EKG with a GXT, and then also some electrolyte abnormalities. But for this part of the course, the U wave, with exercise on a normal GXT, it's normal for an upright U wave to form with exercise. Usually, and again 70 shows the example in the bottom, also on 70, usually this is most commonly seen in recovery. You don't see it right at the end of exercise, but when you have somebody lie down after, a lot of times you see the U wave. And this is normal as long as it's upright above baseline. Okay, the next one, or next two together actually, have to do with the QRS complex duration and axis. And this is, there's an example on page 71. First off, the easier of the two is the duration of the QRS complex. It is normal to have no significant change in QRS complex duration with exercise. In other words, the QRS complex has a certain distance at rest, and we looked at measuring that early in the course, and that should not change with exercise. It should stay the same, QRS complex duration. So pretty straightforward on that. It is normal to have a QRS complex axis shift to the right with exercise. And we'll talk about why in a minute, but if we take a look at page 71, this was a patient who had an axis of about 60 at rest when we took an EKG. And during exercise, I want you to potentially pause before I talk you through this, pause this information, and actually do the axis yourselves. And if you do the axis, you'll find that the most isoelectric lead is lead AVR. And AVR's perpendicular lead is lead 3, and lead 3 is upright. So the axis on this EKG on page 71 is 120 degrees, 120, and that's a right axis deviation. And again, at rest, the axis was about 60, so there was a shift to the right. This is normal with exercise and commonly seen, not seen all the time, and this is a very pronounced example, but it's normal to have some of this right axis shift for two reasons. One of the reasons is anatomical, and that's that where the diaphragm during breathing, deeper breathing during exercise, tends to anatomically pull the heart vertically, pull the heart a little bit to the vertical area, and therefore pulling it to the right. And so that's an anatomical reason. The other reason is a transient hypertrophy of the right side. And this is similar to some discussion earlier where a lot of blood returning to the heart goes to the right atrium and right ventricle, and the right side gets bigger, and that transient exercise hypertrophy will pull the axis a little bit toward the right, or pull it down and to the right, and you'll get that potential right axis deviation. Okay, the next one is the QT interval, and this is on page 72, and we will be talking again later about the QT interval regarding some abnormalities, but again, this is the normal EKG response during the GXT. And the QT interval should shorten with exercise. It's normal for it to shorten with exercise based on the heart rate being faster. We looked at this earlier in the course where on page 4 in the Dr. Bing text, there's a chart in there where it shows the QT interval based on the heart rate, and it should be, as the rate gets faster, it should be getting shorter. As the rate's slower, the QT interval can be longer. So that's straightforward out of that chart that we had looked at. You can see the example on page 72 where the QT interval at rest is a little bit long, actually, in this example, but it gets quite a bit shorter with exercise. So that's a normal thing. If it stays the same or lengthens, that's abnormal, and we'll look at that in a few minutes. But anyway, it should get shorter with a faster rate and with exercise. The last one for normal EKG response during GXT is referred to as the septal Q wave. We've talked about septal Q waves earlier in the course as being normal Q waves on the EKG. They're usually very small, and they have to do with normal depolarization of the interventricular septum. So with exercise, it is normal for the septal Q waves to form. So you may have a situation where, like on page 73, where they are, barely there or absent at rest, hardly anything there, and so it's normal for them to form during exercise. You can see where the arrow is in each example, or if they, if they're there a little bit at rest, it's normal for them to increase with exercise, to get a little bigger with exercise, and this is actually a good sign if you form or increase septal Q waves during exercise, and that's a good finding and shown on page 73. That concludes all of the normal EKG response during GXT and all of the things that should happen. So we want to make a slight shift here to abnormal EKG response during GXT. And now you want to be thinking in terms of not so much testing of, say, apparently healthy individuals or athletes, but you want to be thinking in terms, or you should be thinking in terms of testing clinical patients. And generally, the EKG is used for diagnosis of heart disease, And so we're mainly talking about cardiac patients or heart patients. And we've talked a little bit about this already in the course, but this is where we put it all together and actually do some measurement of exact interpretation. So this is titled then Abnormal EKG Response During GXT. And the first item, clinical item on this, or area to diagnose, and the most important one and the most common one, is the idea of ischemia. And this is on pages 74, 75, and 76 in the course pack, looking at ischemia. And we have been saying that ST segment changes, either depression or elevation, are representative of ischemia. So just to look at reading the statement then, the normal ST segment should not be elevated or depressed very much. And if you look at page 74, the first beat on page 74, in the upper left corner, there's hardly any ST segment depression. It's pretty much at baseline. But if you follow that EKG during exercise, so going from left to right with that EKG, these are actually composite beats where the machine has taken every 2 minutes and composited this into a beat, made one beat out of it. And so you can track the tests at 2 minutes, 4 minutes, 6 minutes, 8, and so on. And some of this actually goes into recovery too. But what we're seeing here is the ST segment depression shown on this, and there's other examples in a few minutes, represents subendocardial ischemia. So lack of oxygen, ischemia is lack of oxygen to the inner layer of the heart, referred to as the subendocardium, or sometimes the endocardium. And there's a lack of blood flow and therefore oxygen. So if you look at page 74, you can see throughout, going from left to right, that the ST segment continues to get quite depressed. And that's a classic example of subendocardial ischemia. If you look at the bottom example on page 74, you can see at rest that there's actually a little bit of normal elevation of the ST segment, and that's within normal limits at rest. But then during exercise, you have quite a bit of very significant ST segment depression on page 75. And then also on page 76, you have several examples, just the same thing over and over, of ST segment depression. And again, that other EKG where we want to actually look at how to determine the exact amount of that, but we'll do that in a few minutes. So this first concept then, that is that ST segment depression is representative of subendocardial ischemia, and we will be measuring the exact magnitude of this in a few minutes. And this is the common thing that you will see as a clinical exercise physiologist day in and day out, all the time. You might do 6 or 8 or 10 exercise tests on cardiac patients, and you might see this 3 or 4 times in a given day, this idea of ST segment depression representing subendocardial ischemia. A lot of these patients have symptoms of angina, and they end up going to the cath lab for a catheterization, and a lot of them end up having angioplasty or bypass surgery, and it's a very common, day in and day out scenario. So it's important, and we'll come back to measurement of the exact magnitude of the ST segment depression in a few minutes. The other item here is ST segment elevation, and this is something that we actually touched on earlier in the course also, but you'll see this every once in a while, not that common. Maybe you're testing a lot of patients every day for a month, and you might see it once or something, so it's not very common. But the ST segment elevation, as shown on page 76, is representative of transmural ischemia, where the ischemia goes through the entire myocardium. So it's not just in that subendocardial layer, but it's through the entire myocardium you have ischemia. So a lot of area of ischemia. And this is generally due to a coronary artery spasm during exercise. Could happen at rest too. But a spasm is where the vessel actually clamps down so there is no blood or oxygen through the entire myocardium, and therefore it's transmural. Page 76 is a good example where at rest, V2 and V3, ST segment's normal, and then V2 and V3, you have ST segment elevation. This was a woman of about age 75 to maybe late 70s, and she was doing an exercise test and had a coronary artery spasm, and she had all of that ST segment elevation. We gave her what's called sublingual, under the tongue, nifedipine, and within about 3 or 4 minutes she had actually reversed right back to normal, and she didn't have any heart damage with that. We corrected the spasm, and she was okay. So again, the elevation is usually a spasm. It's usually due to transmural ischemia, and it's usually not that common. We won't say a whole lot more about transmural ischemia for this course, but that's a good example of that. We'll be getting back more to the measurement of the subendocardial ischemia in a little bit. First of all, though, the mechanism of ischemia, and this will be an essay question on the final exam, is that there's a supply and demand mismatch in the heart, where at rest, if you have a little bit of demand for oxygen in blood, you can supply it very well. And if you have normal coronaries, coronary arteries, you can still, even though you're increasing the demand for oxygen during a GXT, you can still supply it so you get a normal response and no ischemia. The ischemic heart has a mismatch where during an exercise test, the heart is demanding more oxygen and blood and not getting it, and therefore there's a mismatch, and this, again, usually happens with exercise, and this is why somebody would become ischemic during exercises, because they can't supply enough oxygen and blood to the heart, and therefore they generally get ST segment depression. Moreover, ischemic cells will leak potassium. They just get the permeability of the lining of the cell kind of weakens, and potassium leaks out. And as we said earlier in the course, potassium going back into a cell is the repolarization process which forms the ST segment. And if it's going in but leaking out, it's still sticking in, some of it, but it kind of leaks out, so you get some in, some leaks out, more in, some leaks out. Eventually it does all get in there, but that leaking makes it slow to repolarize, and therefore you get ST segment depression with that slowly repolarizing process. The next area on this is looking at measurement of the magnitude of the ST segment depression, and I've been kind of referring to that throughout, and we have a couple of slides where we'll actually look at that and measure the ST segment depression, and then look at the criteria for a positive exercise test for exercise-induced ischemia. So if you, first of all, this pertains to the ST segment depression, and we're really saying, how much is there, how much ST segment depression is there, and we're trying to make a diagnosis of a negative versus a positive GXT for ischemia. Trying to look at whether it's negative or positive. If it's negative, then the person is generally told that they do not have coronary artery disease, and they're sent home to be watched and monitored. And if it's positive, then they are told that they have coronary artery disease, and often are admitted and sent to the cath lab, and then have that procedure, and then maybe some correction after that. So first off, 1 millimeter, and this is on your slide, or more, of horizontal or downsloping ST segment depression is considered to be positive for ischemia. 2 millimeters or more of upsloping ST segment depression is positive for ischemia. So anything less than that would be negative for ischemia. So if you had a 0.5 millimeter of horizontal ST segment depression, that's negative, but if you had, say, 1.5 millimeters of horizontal ST segment depression, that's positive. And then the same concept with upsloping ST segment depression. I want to look at the next slide on how to read the exact amount of ST segment depression, and then look at some examples of this. So what you want to do then is find the top line first. And this is the baseline or the isoelectric line, and this can also be changed if there's a TA wave. This is one of the things that we said we would come back to. The TA wave would actually push the top line down a little bit, and we'll look at an example of that. And then you want to find the J point. And the J point is at the top of the S wave. This can be underneath the baseline, at the baseline, or above it. You find the J point. And then you want to count 2 boxes to the right of the J point and find where the EKG is marking at that point. And then you want to measure the distance from the top line to the bottom line, and then determine, that would give you a number, and then you also determine the slope, and then you fit all that information back to a determination of whether it's negative or positive. And so that's a lot of information, but let's look at an example as we go through that. And so if you go to the next slide at the top, you can, first off, you want to find the top line. And there is no TA wave on this first one, on this slide. So the top line is the isoelectric line where you can see the P wave, and then it goes into a flat area, and at the beginning of the Q wave, and then you can also go way to the right of the T wave, and that's all the isoelectric line. That's your top line on there. And feel free again to, as we go through this, to kind of pause or look back and forth at what we're looking for. Then the next step is to find the J point. And the J point is where the S wave is coming from its lowest point and ascending, and then has a change in slope. So you can see there's a very, on this example, a very drastic change in slope. It goes from basically vertical to horizontal, and that's your J point. And the J point then is, you can go to the right of the J point by 2 small boxes. So count over to the right, and when you count over to the right, and these boxes are enlarged, they would be generally millimeters, but they're enlarged for teaching example. You go to the right by 2 small boxes, and you find where the line is. And then you determine the amount of ST segment depression from the top line to that 2 boxes past the J point line. In this example, it would be 2 millimeters, 2 boxes. Now, again, these are not actual millimeters because it's enlarged, but if you were reading an EKG, it would be 2 millimeters. So 2 millimeters of ST segment depression. The slope of this is from the J point to the 2 boxes past the J point, and it's horizontal in this example. So if you go back to the criteria, then you have, in this case, 2 millimeters of horizontal ST segment depression, and that would be positive for ischemia because you're more than 1 millimeter or more of that. So again, this is a good time to try these and maybe, slow down or pause my reading of this and try this on your own. If you look at the next one down, you have, this is just on that same slide below the first one, you have again no TA wave. So where the top of the Q wave, or if you look at before the P wave or after the T wave, that's all your isoelectric line, your baseline. We've studied that early in the course. And then you want to find that'll be your top line. You want to find your J point, which is where the S wave is coming up, and then it starts to go not horizontal, but it starts to change its inflection. And you find that J point. And then you count over 2 boxes to the right from the J point, and you follow your EKG line. And when you're following that, then you see that it's actually going back right to the baseline. And so in this case, you have, if you're measuring the distance, then the amount of ST segment depression, you don't have any. You have the exact bottom line is at the top line. So there's 0 millimeters of ST segment depression. It's upsloping, and therefore clearly this would be a negative test. No ST segment depression, upsloping, and therefore negative for ischemia on that example. So if you go back to the previous slide, you have your just a mechanism of doing this, and again coming up with an interpretation and following these answers. So if you that next slide gives you those 2 examples, and if you go forward to another slide, the next slide gives you the answers. Just what we said with the 2 millimeters positive for ischemia and the 0 negative for ischemia. And then if you want to maybe look at the next slide with a couple more examples, I would recommend trying this on your own, and then I'll talk through it. So if you want to pause and maybe look at this one, it gives you a couple more examples of this. On the first one, you have, in this case, a TA wave, which is actually lowering the top line by 1 millimeter. And again, this is an enlarged millimeter. And then your J point is pretty clear, and then it makes a real drastic change in slope. If you count 2 boxes over from the J point, you can see that you are, in this example, 3 millimeters depressed from the top line. And if you didn't know about the TA wave, you would actually read this as 4 millimeters, but that would be incorrect. So 3 millimeters depressed. And the slope of this is horizontal. So if you have 3 millimeters of horizontal ST segment depression, that's positive for ischemia, and you can check that by looking forward to the next slide. 3 millimeters of horizontal ST segment depression positive for ischemia, and then it gives you the information on the TA wave also. The one below that, the example, also has a TA wave and a J point that is 1 millimeter below the TA wave. And then if you count over 2 boxes, you can actually see that the ST segment depression is not depressed at all. In fact, it's elevated by 1 millimeter. It's actually right at the baseline, but the TA wave line is 1 millimeter below the baseline, so you're actually over by 1 millimeter. You can be a little bit above like that, so that's normal also. So I would read that one as being 1 millimeter above the baseline. The slope is upsloping. This is negative for ischemia. And again, note the presence of the TA wave on there as you're looking at that. So that's the reading of the electrocardiogram for ST segment depression. And that's a pretty important part of this course, because a lot of clinical exercise physiologists will be reading EKGs and making a diagnosis and determining or helping, as part of the team, determine the fate of the patient from there. So that's the under the category of abnormal EKG response during graded exercise testing. That's the most important area to study and look at and really understand, is that idea of ischemia and all of the reading of that. There are a few more items to finish under abnormal EKG during GXT, and the first one after ischemia, so number 2, is dysrhythmias. There's an example on page 77 in the course pack with runs of VTAC, ventricular tachycardia. And the statement here is that it's abnormal to induce dysrhythmias or have dysrhythmias increase with exercise. You do not want to induce dysrhythmias or have them increase in frequency from what they were at rest. So if you have somebody with a few PVCs at rest and you have a lot of PVCs during exercise and even VTAC, that's not a good thing. That's abnormal. I've seen a lot of cases where resting dysrhythmias tend to even go away with exercise, and that would be a good thing. So you do not want them to increase. The next one is the QT interval on page 78, and we said earlier that it should shorten. If the QT interval prolongs or stays the same, so if it lengthens or stays the same with exercise, that's abnormal. And on page 78, there's an example where this person that I was testing had chest discomfort during the GXT, and we looked for ST segment depression and saw none, which is usually inconsistent with what should happen. But we did see that the QT interval was not shortening, and you can see it under the chest discomfort. If you measure, that QT interval, you'll have a situation where it's about the same as it was at rest. There's no shortening of the QT interval. This is a person that, with a lack of QT interval shortening, they had ended up having single vessel disease and had a catheterization and had a balloon put in, or angioplasty with a stent, and it corrected it. So again, it should not stay the same or lengthen with exercise, the QT interval. The next one we referred to earlier also referred to this under the normal EKG changes. And we said that the R wave, S wave, and QRS complex amplitude should, they can increase during submax exercise normally, but they should decrease at max. If they continue to increase, that's an abnormal finding. as shown on page 79. So it's abnormal for the amplitude, these amplitudes to keep increasing at peak. And you can see on page 79 that they, if you go from left to right, they keep increasing. This is mainly the R wave in this case. And this indicates that the heart is failing. The blood is not being pumped off like it should. The end systolic volume is increasing because it's not being pumped away. And there's exercise-induced left ventricular dysfunction, or it can also be called heart failure during exercise, if that continues to increase, like that example on page 79. The last one for abnormal EKG changes during GXT is U-wave inversion. And this is on page 80. We said that it is normal to have U-waves form during max exercise, or especially during recovery. It's normal as long as they are upright. But it is abnormal to induce U-wave inversion with exercise. Most of the time you see this in recovery, and it doesn't happen very often, but it's not a good sign if it does happen. So we refer to this as the idea of sensitivity and specificity. This is a specific sign of ischemia, but not sensitive. Again, meaning that it's not very sensitive at picking up ischemia. It doesn't happen very often, but if it does happen, it's generally almost all the time, 97% of the time, a very accurate response. So this concept of sensitivity specificity is not testable for this course. We'll expand on this later in the curriculum and other courses, but the key point here is that you should not have U-wave inversion with exercise. That's an abnormal sign. So that concludes the normal and abnormal EKG response during GXT. And again, for a clinical exercise physiologist, that's an important area in this course. We'll shift a little bit then to still under this part 1 of this module, module 4, but some additional information, and take a look at some other information in the course back and also in the text on this. In the first area is the pulmonary effect on the EKG. Now, generally, to look at pulmonary disease, you want to do spirometry, which is a measurement of lung function. Maybe some of you have had that, where you breathe into an instrument and you can determine lung volumes and flow of air. And that's the usual way to do that, and that's the most diagnostic way. But we do want to be aware of, for this course, since it's an EKG course, that pulmonary disease sometimes does alter the EKG in some ways. And so this will be fairly quick, but we want to look at some of these things that can occur. And you can follow this in the Dr. Bing text, pages 24 and 25. It's also examples shown in the course pack, and we have actually no examples on this in the course pack, just you can look at examples in the text, the small text, but there's information on these slides. The first area then is acute pulmonary effect, where this is happening right now. Somebody's having a pulmonary problem right at the moment. And in this case, you have maybe like a asthma, maybe exercise-induced asthma. And on EKG, you'll often see, and again, this is in the small text, sinus tachycardia, maybe some STT wave changes, maybe a slight shift of axis to the right, and potentially development of right bundle branch block. You do not see this all the time, but these are some things that are correlate with an acute pulmonary situation or effect on the EKG. If somebody has chronic pulmonary disease, they often have a lot of air in between the electrode where you're taking the EKG and the heart itself. And again, if you look at the small text, you'll see an example of this, but what we often see because of that air in between is low voltage. And the low voltage is where you have the QRS complex is usually less than 5 millimeters in the limb leads. So you have just not a lot of amplitude or voltage on there. And again, it's because of that air in between. And this is kind of a common thing to see if somebody has chronic pulmonary disease, like a lot of retaining of air in that situation. You can also see an axis shift to the right, sometimes with chronic pulmonary disease. And so these are a few things just to make the course, for completeness of the course to think about. But again, the EKG is not something you're generally using for diagnosis of pulmonary disease, but it can be helpful, say like additional tool, along with spirometry and other pulmonary function testing parameters. Okay, another area to look at with EKG, and this is in the small text on page 32 and in the course pack on pages 81 through 83, and this is the electrolyte effect on the EKG. And we'll go through several of these and give examples. And the first one is where you have low potassium or hypokalemia. And on the EKG with low potassium, and this is seen especially well on page 81 in the course pack, you'll get formation of U waves. We've talked a little bit about U waves here and there, and you can recall that they could form, for example, during exercise. But if you have somebody with resting U waves, the wave right after the T wave and before the next P wave, as shown with the arrow, you can, this could be because they're low in potassium or hypokalemic. And you could get ST-T wave changes potentially. This would mean like flattening of the ST segment, T wave, maybe ST segment depression, maybe T wave inversion. And you can also get dysrhythmias with hypokalemia, things like PVCs and other dysrhythmias. Just as an aside note, hypomagnesemia also causes dysrhythmias. So a lot of your patients that might be consuming or taking diuretics, they lose electrolytes, or if they consume a lot of coffee or caffeine or alcohol, they could lose electrolytes like potassium and that's one of the things that would cause dysrhythmias in the heart. Okay, the next one is the opposite side of this, hyperkalemia. This is high potassium. And this is where you get a sequence of events in order as shown on this slide. The first item that usually happens as the potassium increases is peaked T waves that are kind of tall. On page 81 with the arrow, you can see that tall T wave, and a lot of times if the T wave is bigger than the R wave, that's a kind of a clue toward hyperkalemia. So peak T waves. If the potassium gets a little higher, you could have wide QRS complexes. QRS starts to widen. And then the P waves tend to flatten out, and then eventually, if too much potassium is there, the heart can actually go into asystole or stop. This is generally not a situation for somebody that just, say, eats a lot of potassium. It's usually if they have, and not even a situation generally for a metabolic problem with potassium. Those are, generally you'll have the T wave peaking and stuff like that with overconsumption of potassium or metabolic problems. These other problems like asystole usually come with some kind of clinical situation where maybe somebody has taken a medication that increases potassium, and then they take potassium supplements, and then they get way too much potassium, and that's where it can be dangerous, and you could get potentially asystole. And then another example of that is if somebody is sentenced to a lethal injection, part of the injection cocktail is giving a lot of potassium to stop the heart. And I don't know if EKGs have been done in that case, but they would see this sequence of events, including the asystole, stopping of the heart. So that's hyperkalemia. Let's go next to calcium. And this is also in the text. This is on page 32 and then in the course pack. And if you think in terms of calcium, there's an opposite effect on the QT interval. In other words, if you have hypocalcemia, low calcium, you'll have a long QT interval. And you can see on page 82 in the course pack the in these examples, very long QT interval. So hypocalcemia, long QT interval, kind of an opposite effect. Too little, too long, that type of thing. And then if somebody has hypercalcemia, too much calcium, high calcium, they get, again, that opposite effect of a short QT interval. And this is a case on page 83 in the course pack where somebody has what's called Ewing's sarcoma, This is a type of bone cancer, and in this case, calcium is leaking out of the bones into the bloodstream and leading to a hypercalcemic situation, a lot of calcium. And you can see that on the CKG, the QRS complex goes right into the T wave, and the QT interval is very short. So again, you have that kind of an opposite effect of too much, too short. That's the way I remember it. Hypercalcemia, short QT interval, like that. So those are some electrolyte effects on the EKG. And generally with electrolytes, we would want to also think in terms of taking a blood test to confirm that too, to look at the electrolytes. The next topic is the drug effect on the EKG. And the drug effect on the EKG is shown in the small text, where on page 33, certain medications or drugs, and these are generally prescribed medications, have implications on the EKG. And the first area is the category of drugs including quinidine and procainamide. These are ventricular antiarrhythmic medications. And these will lead to QT interval prolongation. And one of the ways that they work as a ventricular antiarrhythmic is to prolong the QT interval a little bit, and you can get rid of or lessen the number of PVCs. But if you lengthen this too much, these could actually be paradoxically proarrhythmic, where you could get a PVC, and we talked about this earlier in the course, hitting the T wave and causing things like VTAC. And so these can be used, but you want to be very careful in the use of these medications like quinidine or procainamide, because if you get too much in there, the proarrhythmic effect can be very dangerous. And so you want to just be very careful with the use of these. Another key cardiac medication is digitalis, and we mentioned this earlier in the course also. And what digitalis does most commonly is it causes ST segment depression in a scooping morphology, kind of like a scoop, like a shovel, and it looks like ischemia. So the scooping morphology can be mistaken for ischemia, and therefore somebody could say, they're ischemic, but it's really false. It's due to the medication. That would be false positive GXT for ischemia if somebody's on digitalis. So you want to be aware of the digitalis effect on the EKG, and then before you make an interpretation of ischemia in your patient, make sure that they are not taking digitalis, because it can give you that false positive impression. The other thing that digitalis can do is cause PVCs and other dysrhythmias, and this is usually if you have too much digitalis. And what you want to do is, if you start to see a lot of PVCs or dysrhythmias, is back off on the amount of digitalis, and they may need it as a medication, but give less of it so that they don't have these dysrhythmias. So that information then on the drug effect on the EKG, along with everything else, concludes part 1 of Module 4, and we'll go next to part 2 of Module 4, and again, all of this goes toward Exam 4.